The American College of Radiology.
Focused forward.
Together.
Welcome, everyone, and thank you for joining us for this ACR webinar on O-Rads MRI. We will walk you through the foundation of O-Rads MRI by providing you with a guide to the lexicon, risk score, and technique. I am Erica Stein from the University of Michigan, and I will be joined by Dr. Krupa Patel Littman from Vanderbilt University Medical Center and Dr. Elizabeth Sadowski from the University of Wisconsin. We have no relevant disclosures. Let's review the learning objectives for this webinar. At the conclusion of this presentation, learners will become familiar with key O-Rads MRI lexicon terms to describe both fluid and solid components, and also recognize the 5 different categories of the O-Rads MRI risk score. Learners will understand the technical requirements needed to use the score in practice. And lastly, learners will become familiar with an easy algorithmic approach to scoring adnexal lesions using O-Rads MRI. This webinar will be divided into 3 sections. I will start us off with part 1, where I will cover background and resources for O-Rads MRI and a review of the lexicon. Next, Dr. Patel Littman will present part 2, the risk score and technical requirements. And Dr. Sadowski will help us put all of this information into practice with a straightforward algorithm for scoring lesions. So how did the MRI risk score come about? Well, the ACR O-Rads committee, comprised of experts in the field from around the world, came together, and based on the ADNEX MR score, they developed the O-Rads MRI score. O-Rads is unique in terms of its strong evidence basis, with the risk stratification system based on prospective data from more than 1,500 women. The O-Rads process was launched in 2015, and the O-Rads MRI risk score was published in 2020. The goals of using the O-Rads MRI risk score is to improve communication, not just between ourselves as the radiologist, but also with our referring physicians. Radiologists at any level of training can use the O-Rads MRI scoring system, and the ultimate goal is to reduce variation and improve accuracy in reporting. A quantified scoring system also allows for patient outcomes research. The ACR website is a great resource to find all of the relevant information and documents related to O-Rads in one location. You can type in ACR O-Rads into any search engine, and the first result should take you to the ACR website. Not only does this site include links to relevant tables and algorithms, but also includes links to relevant O-Rads publications. At the bottom, where the green arrow is, you can choose either O-Rads ultrasound or O-Rads MRI. If you click on the MRI image, it will take you to this next screen. Each of these subheadings on the bottom half of the page contain hyperlinks to additional helpful material. For example, there are documents that provide MR technical guidance, O-Rads MRI template samples, and there is a link to the ACR O-Rads e-learning module. If you click on the first subheading, the governing documents and tables, you will find some of the more frequently used documents, including the O-Rads MRI assessment categories table and lexicon terms table. The term ACR uses for risk stratification is assessment categories, so you'll find the scoring system there. Another great resource is the O-Rads MRI calculator. This is a web-based calculator that can be accessed at oradsmricalc.com using this QR code or following the link on the ACR O-Rads website. This uses an algorithmic approach to assist in assigning a risk score. This is a great tool to use, especially when you are first starting to learn the O-Rads MRI lexicon and descriptors, as it reinforces important concepts. As you can see from the screenshot, there are 4 straightforward questions that serve as the foundation for the MRI calculator. Next, we will review the O-Rads MRI lexicon. On the next 5 slides, we will go into more detail about the descriptors used in the O-Rads MRI lexicon with imaging examples. An important distinction to make is to determine what is physiologic. Both a follicle and corpus luteum are considered physiologic, and anything that is not physiologic is considered a lesion by O-Rads. And there are certain lexicon terms we will review, such as unilocular, multilocular, and solid, that are used to describe non-physiologic lesions. We will also review both fluid component descriptors and solid component descriptors in more detail, giving you the tools to utilize O-Rads MRI in your daily practice. Let's start out by talking about physiologic findings. Both a follicle and corpus luteum that measure 3 centimeters or less in a premenopausal woman are considered physiologic. Here's an example of a benign physiologic cyst or follicle containing simple fluid. The fluid is hyperintense on T2, hypointense on T1, and does not enhance. And here is a classic corpus luteum at MRI, which can exhibit variable signal on T2 and T1, but displays a classic enhancing crenulated wall on post-contrast T1 weighted sequences, denoted here by the arrowheads. And next to the corpus luteum is an incidental endometrioma, which is not considered physiologic. Now let's turn our attention to non-physiologic lesions. Using the O-Rads MRI lexicon, cystic lesions can be further subdivided based on the number of loculations, either unilocular or multilocular. The definition of a unilocular cyst is one where there is a single compartment or chamber and no complete septation. In this example, the white arrow is pointing to a left adnexal unilocular cyst. A multilocular cyst, by definition, contains more than one locule and at least one complete septation. In this example, there are multiple thin septations denoted by the arrowheads. A unilocular or multilocular cyst may or may not contain solid tissue. In this example, there is a large unilocular cyst containing enhancing solid tissue. The white arrow points to the T2 weighted intermediate signal papillary projection along the anterior wall that clearly enhances following contrast administration. Now let's talk in more detail about the types of fluid we may encounter in cystic ovarian or adnexal lesions. There are 2 main categories to consider, either simple fluid or non-simple fluid. And under the non-simple fluid category is proteinaceous or mucinous fluid, endometriotic fluid, and hemorrhagic fluid. Here's an example of an ovarian cyst containing simple fluid, which is hypointense on T1 and hyperintense on T2 weighted imaging. The low T1 signal should be lower than adjacent skeletal muscle, as we see in this example. Simple fluid content will follow CSF or urine on all sequences. In addition to physiologic cysts, there are also cystadenomas that may contain simple fluid. This is an example of a multilocular cyst containing proteinaceous or mucinous fluid. This fluid will have variable signal on T1 and T2 weighted imaging, as in this case, where each locule is exhibiting slightly different signal characteristics. But on T1 weighted imaging, the signal of the fluid is typically higher than adjacent skeletal muscle, in contrast to simple fluid. Here's an example of endometriotic fluid in an endometrioma. There is homogeneous hyperintense signal on T1 weighted imaging with intermediate to low signal on T2 weighted imaging, also known as T2 shading. The T2 shading occurs due to repetitive hemorrhage and accumulation of blood products of varying age within the endometrioma. Subtraction sequences are very important to exclude any enhancing solid tissue in an endometrioma, given the intrinsic hyperintense signal on pre-contrast T1. If enhancing solid tissue is present in an endometrioma, this may suggest malignant degeneration. And lastly, hemorrhagic fluid can also display variable signal depending on the age of the blood products. Diagnosing hemorrhagic fluid in a lesion can be a challenging diagnosis, and there may be overlap with proteinaceous or mucinous fluid. But regardless, there will be no change in the O-Rad score. In the late subacute phase, as in this example, the blood is typically hyperintense on both T1 and T2. And you may ask yourself, what is the difference between an endometrioma containing blood products and hemorrhagic fluid? Since there are blood products of varying age within endometriomas, it is the presence of hemosiderin that contributes to T2 shading, and this T2 shading may help differentiate endometriomas from hemorrhagic fluid. Let's switch gears and talk about the definition of solid tissue and the different O-Rads lexicon descriptors. First and foremost, for a solid component to be considered solid tissue, it must enhance at MRI. So things that do not enhance, like blood clot or fat, are not considered solid tissue. If there is enhancing solid tissue, it should conform to one of the following morphologies: nodule, papillary projection, irregular cyst wall or septation, solid portion, or solid lesion. A nodule is defined as enhancing solid tissue with a nodular appearance, measuring at least 3 millimeters and arising from the wall or septation. In this post-contrast example, the white arrow points to an enhancing nodule within a multilocular cyst. The definition of a papillary projection is enhancing solid tissue arising from the inner or outer wall or a septation with a branching architecture. In this example of bilateral serous borderline tumors, 2 different growth patterns of papillary projections are displayed on this T2 weighted image. On the patient's right, the frond-like papillary projections are growing exophytically along the surface of the ovary, whereas on the patient's left, there are endophytic papillary projections arising within a unilocular cyst. An irregular septation demonstrates an uneven margin that varies in thickness along its length. In this post-contrast example, there are irregular septations denoted by the arrowheads, with variable thickness and uneven margin. If you have an enhancing component that does not fit into one of these 3 categories, it can be termed other solid portion. If, on the other hand, the lesion is at least 80% solid tissue, then it is considered a solid lesion. Another way to think of this is that the cystic component is less than 20% of the total volume. In this post-contrast example, the entire lesion is comprised of enhancing solid tissue. As already mentioned, there are solid components that are not considered solid tissue per the O-Rads Lexicon and are rather exceptions to the rule. Let's go over these 4 exceptions, which include clot, smooth septations, fat, and Rokitansky nodules. Non-enhancing clot, debris, and fibrin strands are not considered solid tissue. In this example, there is a unilocular cyst containing dependent T2-weighted intermediate signal material. And while this is solid appearing on T2, we can see that on the post-contrast T1-weighted sequence, there is no enhancement, confirming our suspicion that this represents dependent clot and not solid tissue. Here's an example of a multilocular cyst on T2-weighted imaging, containing several smooth septations. An even contour or margin is not considered solid tissue. In this example, we have macroscopic fat within 2 adjacent dermoid cysts. Lipid-containing material that does not enhance is also not considered solid tissue. The white arrows point to hyperintense tissue on the non-fat saturated sequence, and subsequent loss of signal in these locations on the fat-saturated sequence confirms presence of macroscopic fat in these dermoid cysts. And the last example of a solid component that is not considered solid tissue per O-Rads MRI is a Rokitansky nodule. Minimal enhancement of a Rokitansky nodule in lipid-containing lesions would not upgrade the O-Rads MRI score. Here's an example of a dermoid cyst containing a small enhancing Rokitansky nodule, denoted by the white arrow. Now, with this foundation and familiarity with the O-Rads MRI lexicon, it is now time to turn it over to Dr. Patel Littman, who will talk to you about the risk score and MR technical requirements.
All right, so we're going to move on and start discussing the risk score here today. So this is the risk assessment table, which is really the workhorse in the evaluation of adnexal lesions. You're going to see the 5 respective risk scores and categories, the corresponding positive predictive value for malignancy, as well as the lexicon descriptors of lesions within each of these categories. At its basic level, the risk score divides lesions into benign, low risk, and intermediate risk or malignant lesions. O-Rads MRI 2 lesions are benign. This includes simple cysts, classic benign lesions such as dermoids, endometriomas, most hemorrhagic cysts, as well as fibromas. O-Rads 3 lesions are low-risk lesions. This includes larger hemorrhagic proteinaceous cysts with rim enhancement, multilocular cysts, and lesions with enhancing solid tissue with low-risk curve. O-Rads MRI 4 and 5 lesions include lesions with enhancing solid tissue with higher risk enhancement curves. So we're going to go ahead and review each of these categories in more detail. So O-Rads MRI 1 are normal ovaries. This includes no ovarian lesion or physiologic observations seen in premenopausal women. This includes follicles, which are defined as simple cysts less than 3 centimeters in size, hemorrhagic cysts less than 3 centimeters in size, and corpus luteum. You can see an example here of a corpus luteum on these lower images demonstrating a crenulated margin and a thin enhancing wall. So O-Rads MRI 2 lesions are almost certainly benign, with a positive predictive value for malignancy of less than 0.5%. This category includes unilocular simple cysts with or without wall enhancement. You can see this example here on the right of a simple cyst, T1 hypointense, T2 hyperintense with a thin enhancing wall. All unilocular cysts with no wall enhancement, regardless of the type of fluid, are O-Rads MRI 2. Hemorrhagic cysts without wall enhancement are also O-Rads MRI 2. Hemorrhagic fluid can have variable signal intensity fluid based on the age of the hemorrhage. This is an example here on the right demonstrating late subacute hemorrhage with both T1 and T2 hyperintense fluid. Endometriomas are also benign. Classic endometriotic fluid is T1 hyperintense and demonstrates either hypointense or intermediate T2 signal called shading. Similar to simple cysts, endometriomas can also have a smooth, thin enhancing wall and still be considered O-Rads MRI 2. T2 dark nodules or linear foci in the wall are also a specific ancillary finding often seen in endometriomas. Dermoids are O-Rads MRI 2 and are benign. Here's an example of a dermoid on the right with macroscopic fat content. The lesion's T1 hyperintense on T1 weighted images with loss of signal on corresponding fat saturated images. The dermoids typically do not demonstrate enhancement, with the exception of small Rodicansky nodules. These nodules typically demonstrate fat within them and may demonstrate enhancement. The key here is to make sure that this is not mistaken for enhancing solid tissue, which we'll discuss a little bit later. So lesions that have solid tissue, but that is both T2 dark and DWI dark, are also considered benign. This pattern is seen in lesions comprised of fibrous tissue, such as fibromas or fibrothecomas. When this pattern is seen, enhancement pattern of the lesion does not affect scoring. Hydrosalpinx, another commonly seen benign finding. This demonstrates a tubular morphology with endosalpingeal folds. Simple fluid with thin enhancing walls and folds without enhancing solid tissue are considered O-Rads MRI 2 and are benign. Similarly, paraovarian cysts are benign. Similar to simple cysts and endometriomas, these can have thin enhancing walls and still be considered O-Rads MRI 2. So what do we notice about these O-Rads MRI 2 lesions? Well, the feature that all of these lesions have in common, with the exception of the T2 dark, DWI dark lesion, is that there is no enhancing solid tissue. The absence of enhancing solid tissue has a negative predictive value for malignancy that is greater than 98%. Okay, we're going to move on now to O-Rads category 3. And these are low-risk lesions with a risk of malignancy of approximately 5% within this category. So this includes unilocular cysts with proteinaceous or hemorrhagic fluid with smooth enhancing wall. Remember that if a lesion is a hemorrhagic cyst with an enhancing wall, but it's less than 3 centimeters in size in a premenopausal female, it's a physiologic finding. It's considered normal O-Rads MRI 1. And as we discussed earlier, unilocular simple cysts or endometriomas that have a thin enhancing wall are still considered MRI O-Rads 2. Multilocular cysts without solid tissue are considered O-Rads MRI 3. These lesions can have smooth, enhancing walls and septations, but no solid tissue. They can have any type of fluid content. If fat is identified in these lesions, though, multilocularity doesn't affect the score, and the lesion is categorized as an O-Rads MRI 2. When solid enhancing tissue is identified in a lesion that is not T2 dark, DWI dark, the enhancement characteristics guide the risk score classification. The enhancement of the solid tissue is compared to the outer myometrium. If there is a low risk curve on time intensity curves, which shows a gradual increase in time without a plateau, a risk score of O-Rads MRI 3 can be assigned. If there are no dynamics or TIC curves available, we cannot score solid tissue as low risk. And finally, dilated fallopian tubes with non-simple fluid or thick, smooth enhancing walls are considered O-Rads MRI 3. All right, O-Rads MRI 4 lesions are considered intermediate risk with a positive predictive value of malignancy of approximately 50%. This includes lesions with enhancing solid tissue, again, excluding T2 dark, DWI dark lesions that demonstrate either an intermediate risk time intensity curve or enhancement less than or equal to the myometrium at 30 to 40 seconds on non-DCE images. You can see on this lower image on the right an example of an intermediate risk curve. This shows an initial slope of the lesion less than the myometrium with the subsequent plateau. The second lesion in this category is the lipid-containing lesion with large volume solid tissue. Malignant degeneration of dermoids is rare, only seen in about 1%. But when there is subjectively a large amount of enhancing solid tissue within a fat-containing lesion, it should be characterized as an MRI O-Rads 4. Here's an example of a fat-containing lesion with large volume solid tissue, and on pathology, this was an immature teratoma. O-Rads 5 categories are considered high risk for malignancy. This includes lesions with solid tissue that demonstrates either a high risk time intensity curve or enhancing greater than the myometrium at 40-second non-DCE acquisition, or the presence of associated peritoneal or omental nodularity. You can see an example here of a high risk curve with enhancement of the solid tissue with a initial slope greater than the myometrium with an associated plateau. The key to remember here is that lesions meeting criteria for O-Rads MRI 5 have a positive predictive value for cancer of approximately 90%. Okay, we're going to switch gears here a little bit and kind of briefly discuss technique. So these are the technical requirements for MRI O-Rads, and these can be found on the ACR website and on the O-Rads MRI calculator. And we're not going to go into details here, except to just highlight a few of the common technical points that we've been seeing sites need to change as they begin implementing O-Rads for adnexal lesion assessment. So T2 weighted images should be attained in at least 2 orthogonal planes, and one of which should be a true axial. Field of view is going to depend on the size of the lesion, but at a minimum should go from femoral head to femoral head, include the entirety of the female pelvic organs, as well as the entirety of the lesion. Extended field of view may be necessary for larger lesions. Slice thickness of 3 millimeters is recommended for axial T2 weighted imaging. And really, this is to avoid missing any small papillary projections or nodules. This is an older case, but kind of nicely highlights how papillary projections can be obscured if 5 millimeter slices are utilized. T1 weighted images within an opposed phase of imaging is important to identify both bulk fat as well as intravoxel fat, which can be seen in dermoid cysts. You'll also notice similarly that the slice thickness is relatively thin, and this is important for finding small volume fat components that can make a lesion benign. DWI should be performed in the axial plane with 4 to 5 millimeter slice thickness. DWI should always be acquired with high B value of 1,000 or greater, with suppression of the fluid signal in the bladder. Again, diffusion is important in the evaluation of solid tissue in combination with T2 weighted images. And thin slices are best to avoid missing those small nodules and papillary projections. You'll notice in this example, the intermediate signal nodule becomes hyperintense on B500, but kind of blends in with the cystic fluid. And on B1000 or B greater than 1000, the fluid diffuses away, and you can nicely see the suspected solid tissue with high diffusion signal. Post-contrast images can be done with or without dynamics. DCE imaging is recommended as time intensity curves allow for better risk stratification of lesions containing solid tissue. If dynamics are performed, pre-contrast and post-contrast images are performed in a single series with a minimal temporal resolution of 15 seconds to ensure accurate TIC calculation. TICs are calculated by placing one region of interest over the enhancing solid tissue within the lesion, and the other on the outer myometrium to taking care to avoid any vessels. The generated curves plot the enhancement pattern of the solid tissue relative to the myometrium over the 3 to 4 minute imaging interval. And as we saw earlier, the slope of the arterial phase enhancement relative to the myometrium and the presence or absence of that plateau determines the type of curve. If non-DCE imaging is utilized, separate pre-contrast and one post-contrast series are obtained. Timing of this post-contrast series is important, timed at 30 to 40 seconds. Assessment of enhancement of solid tissue is binary in non-DCE acquisition. It's either less than or equal to or greater than the myometrium at this time point, and this determines lesion characterization as either O-Rads MRI 4 or 5. And then finally, a subtraction series should be calculated in either method. And really, this is to ensure that non-simple T1 hyperintense fluid is not mistaken for solid tissue, and that these lesions with non-simple fluid are adequately assessed for any associated solid tissue. Okay, so we're going to switch gears again, and I'm going to hand it off to Dr. Sadowski to discuss an algorithmic approach in the scoring of adnexal lesions.
All right, now we're going to move on to learning how to score lesions. And this is the last segment of this webinar. Most of the time you'll find an adnexal lesion and it'll be obvious that it's a endometrioma or a dermoid because of the way it looks. And you won't have to think about it that much because it's classic in appearance. You'll see a lesion that is intermediate signal on T2. Maybe it has some dark areas to it along the wall. It's bright on the T1. It's not enhancing. Or there's a lesion with a lot of fat in it, and you're just going to call it an endometrioma or a dermoid, or O-Rads 2 and be done. Or there are lesions with lots of solid tissue that look like cancer, and you're like, oh yeah, that's definitely cancer. Put it into a 4 or 5. Sometimes, however, you're going to find lesions that are a little more complex or complicated, and they have multiple locules to them, multiple intensities, may or may not enhance, may or may not have fat. And it's these lesions that I want to focus on for the next few minutes and how to approach these. In order to do that, I want to introduce you to an algorithmic search pattern, which actually is the basis of the O-Rads MRI calculator. So if at any time point you need help, you can pull up the calculator and it kind of takes you through this search pattern. So step 1 to the search pattern. First, rule out obvious cancer, i.e., is there peritoneal disease? Is there nodularity along the peritoneum? Is there thickening? Is there omental disease? Are there big lymph nodes? If there's an adnexal lesion, you're going to call it an O-Rads MRI 5. If there's no adnexal lesion, you're just going to call it peritoneal disease and not use the O-Rads system. If there's no obvious cancer, maybe there's no lesion and you just see normal findings. So i.e. you see normal ovary, or you see a follicle or a corpus luteal cyst. You're going to just call that a normal study, or you will rate it as an O-Rads MRI 1. Step 2. So if you've ruled out obvious cancer, you've ruled out normal findings, you find a lesion, you need to look at the lesion and what it is made out of. And the content dictates the score. And the most important thing to start with is whether or not it has fat, and then if it has solid tissue. And then the score will be based on these 2 findings alone, and you don't even have to worry about locules or fluid if these 2 things are present. So let's go into that in a little more detail. You have a lesion, you find some lipid, you have to ask yourself, is there enhancing tissue? If there is no enhancing tissue, or you see a nice little Rokitansky nodule, i.e. a nodule that has some fat in it and is enhancing and is either along the wall or septation, you call it the dermoid and you rate it a 2. If there's a lot of enhancing tissue, large volume enhancing tissue, like in this lesion here, this immature teratoma, you're going to rate it an O-Rads MRI 4. If your lesion has no lipid, your next question is, well, is there enhancing solid tissue? And if that answer is yes, you're going to look at the signal intensity of that solid tissue. Is it homogeneously dark on T2 and the high B value? And if the answer to that is yes, you score it a O-Rads 2, regardless of how it enhances and regardless of anything else. If it is not homogeneously dark on T2 and the high B value, i.e. there's intermediate or high signal in the lesion, in the solid part, then you need to look at the enhancement of that solid component to see if you're going to rate it a 3, 4, or 5. Now say that there is no fat and no enhancing solid tissue. Only then are you going to worry about the number of locules, of which if there are multiple, you're going to put it into the 3 category. If there's only none, if there's no locules, if there's no septations and so only 1 locule, the fluid type is going to matter. And if it's endometriotic or simple, you're going to put it into a 2. And if it's proteinaceous, you'll put it into a 3. And so that's basically the algorithmic approach to adnexal lesions. And all of this, again, is part of the O-Rads calculator. And so if you need help whenever you're looking at a lesion, just pull up the calculator, and that algorithmic approach is kind of there for you. You don't have to remember it or think about it. You just answer the questions. So I want to kind of hone in on a few more points when you're looking at these lesions, particularly ones that are complicated. And so if you want, you could pull down the calculator at this time, because we're going to go over a couple of lesions together. And it might be helpful if you're interested in that. So I'll just pause for a second here and let you pull up the calculator in a separate window. And then we can start this case here. So this case, I already tell you no peritoneal disease. And I don't tell you anything else, except for the age, 52-year-old. And then you have a T1 here, a T1 fat sat, a T2, a high B value, and a post-contrast image. And I guess one of my first questions to you is, before you even tell me what the score is there enhancing tissue here? This is a subtracted image. I still think it's a little hard to tell, is that really enhancing or not? But how about if I give you the curve here? So I think everybody would now see that, yes, there is some level above baseline. The white line is the baseline. Above baseline, that there is some mild enhancement. It's very slow and does not have a shoulder. So that's an important point there. So what would you score this lesion? I'll give you a couple minutes to think about it, and then we'll find out the answer. Okay, so let's use our algorithm. Is there lipid in the lesion? Well, I do see high signal on T1, but that high signal is still there on the fat sat image. So no, there's no fat in this lesion. Is there solid tissue? We sort of already answered that because we had the curve on the previous page. So yes, there's solid tissue in this lesion. So I'm going to look at the intensity of the solid tissue next. Is it homogeneously dark on T2 and the high B value? Well, here it is on the T2, and yes, it's homogeneously dark. And here it is on the high B value, and yes, it's homogeneously dark. Right next to it, there's bright signal, but this is where that fluid was, so that doesn't count. So yeah, this is an O-Rads 2, dark, fibrous tumor. So the enhancement doesn't matter here, the septations don't matter, and the fluid, right? So all these things that are present here, but we don't really need them for the score. If you were using the calculator quickly, you would have said no to question 1. You would have said no to no follicle or corpus luteum, no to fat, yes to enhancing solid tissue, and then it asks you to describe the solid tissue, and you would say, oh, it's all homogeneously dark and up pops through 2. So I wanted to compare and contrast a couple of lesions that were not dark, so that we review what intermediate signal looks like within solid components of a tumor or a lesion. And here on the left-hand side, the yellow arrow is pointing to a solid component that is not dark, and we use our muscles, our pelvic muscles, as the internal control. So this would be dark. If it was as dark as this muscle or darker, and it is not, it is brighter than that. It is higher signal than that. So this is intermediate signal. There is a cystic component with some septations. And then on the high B value, this is very bright, right? So this is not a dark lesion. So we would be using the enhancement pattern here to dictate what the score is. Similarly, on the right here, you see this lobulated soft tissue. Again, using your pelvic musculature, this is higher in signal. It is high in the high B value and it enhances. So we would be using the perfusion curves in order to figure out what the score is on those lesions. And when you're doing the perfusion curves, I just wanted to make mention of a couple important points. First, when you're putting your ROIs on, make sure they're not too big and make sure they are located correctly. And so for the myometrium, it would be in the outer myometrium, but not against the serosa where there's lots of vessels and not next to the junctional zone. So kind of like right in the middle here. And then your next lesion, you want to put the ROI where you see it enhancing most briskly on one of the earlier phases. And again, ROIs do not need to be that big. They just need to capture the areas that are most important for you to see on your curves. And then if you have a flat curve with no shoulder, it's a low risk curve. If there's a shoulder and the enhancement is less than the myometrium, it's intermediate curve. And if there's a shoulder and the enhancement is greater than the myometrium, it's a high risk curve. If you don't have a uterus, you can still differentiate O-Rads 3s from 4s and 5s simply by the shape of the curve. And so if you have a curve that has no shoulder, it'll be a 3. And then if it has a shoulder, you're going to put it into a 4 or 5 category. But you cannot tell them whether it's a 4 or 5. You just have to kind of group them together. All right, next case. So again, I tell you no peritoneal disease on this case. How would you score this lesion? Again, I give you a T1. I give you a T1 with fat set. I give you a T2 and a post-contrast. So I'll just give you a couple seconds here to look at it and come up with the score. All right, so I already told you no peritoneal disease. Does not look like a physiologic thing. There's definitely fat associated with it. And I bet some of you did say, yes, there's a lot of enhancing tissue. And some of you probably said, no, there is not a lot of enhancing tissue. Some of you may have also wanted to make this into a 3 because it's multilocular, multiple septations. But I wanted to point out that multilocular cysts cannot have lipid content, cannot have any enhancing components. So this would not have been rated by its number of cysts, number of septations. So not a 3. It's either going to be a 2 or a 4. And that's the question. Is it a 2 or is it a 4? So here we have our index lesion in the middle where we just finished wondering, is it a 2 or a 4? I think it's a hard question to answer because we really don't have data that defines what large volume is. And I think all of us would agree the lesion on the left, where you see a little nodule off on the side here that has fat in it and enhances, is a Rikitansky nodule, and you can call that a dermoid in a 2. And then the one on the right, there's a lot of solid tissue that enhances, and you wouldn't call that a Rikitansky nodule, and you would call that a 4. But here you've got some solid tissue that enhances. It does have fat in it because you see a little dropout, but not a ton. So I think it's okay to put it in a 4, but I also think it's okay to put it in a 2. And why do I say that? I say that because we don't actually have a defined volume when to call it a 4. And it is, in my opinion, based on your comfort level of seeing these. And in the beginning, when you see these, you may be upgrading some Rokitansky nodules. But I don't think you're going to miss large amounts of tissue. And so let's just talk through what happens if you put this into 4. If you put this into 4, the patient goes to gynecology. This probably is going to come out. It's close to 5 centimeters, and it'll be benign. No big deal, right? You just called it higher than maybe it needed to be, but the right thing happened, right? The patient got the care they needed. Now you can say, well, maybe it shouldn't have come out. Well, if it doesn't come out, it'll be followed, right? And it will either grow or not grow, and that's perfectly fine. Gynecologists can follow lesions even if they're rated higher than they think they should be. Now, say you put this in a 2, and the patient probably would still go to the gynecologist and probably still get it out because of the size or symptoms. And if they didn't get it out, it'd be followed. If it kept growing and it turned out to be a malignant dermoid, they would get it out because of the growth. So either way, you're going to be okay. And I think that you just have to, with your comfort level, figure out where you're going to put this lesion. So there's really no answer to this case, and I know that's frustrating, but that's just the way real life is sometimes. All right, we're going to finish up with the summary statements here. And so first, lexicon, the MR terms that we need for our scoring system are trying to figure out what the finding is. Is it physiologic, like follicle or corpus luteum, or is there a lesion there, a unilocular, multilocular, or solid lesion? And then if there's a lesion, you're going to use fat and solid tissue to begin to score the lesion. And if those things are not present, then you have to worry about other things. In the O-Rads 2 category, you're going to be putting your simple cysts, your endometrioma, your hemorrhagic cysts, and your dermoids. And then you're also going to throw in a fibroma in there. In O-Rads 3, you're going to have your proteinaceous cysts with a enhancing wall, with the caveat that if the patient's premenopausal and that cyst is less than 3 centimeters, you're going to call it a 1. And if it's premenopausal and greater than 3, then you'll put it into 3, O-Rads 3. And all postmenopausal women with a cyst that's proteinaceous or hemorrhagic and enhancing wall, regardless of size, this will be an O-Rads MRI 3. All multilocular lesions with no lipid and no enhancing solid tissue will go into 3. Solid tissue that enhances very slowly with no shoulder, so i.e. a low risk curve, will go into 3. And then everything else goes into 4 and 5. Technique is very important to get the proper O-Rad score and to make those PP, the risk of malignancy scores that you see on the website, valid. So if you're not using the right protocol, the risk of malignancy scores don't hold. And so it's very important to use the right protocol. You can find this on the ACR website and on the calculator so you know what to do. I do want to highlight just a couple things. Slice thickness is important because 5 millimeter slices and above are just too thick for finding papillary projections and small nodules. You really want a high B value because lower than 1,000, there are benign things that can be high signal, and then you may be overcalling cancers. Contrast is important because you want to know if there's enhancing solid tissue and whether you use a perfusion or pre-post with one series afterwards. You want to use 3 millimeter slice thickness to make sure you're getting nice thin slices and finding all that solid tissue that's in there. When you're scoring, an algorithmic approach is helpful and can simplify how you look at these lesions. If there is a lesion, remember lipid and solid tissue. Those are the things that guide the score. And if these 2 things are not present, then you use locules and fluid type. And you can always refer to the calculator if you run into trouble scoring a lesion. Thank you so much for your attention. And I think we're going to head off to question land shortly.